All right. Well, good morning to everybody here in person and those online. My name is Yader Sandoval. Pleasure to be here. Before we start, thanks to the Foundation for organizing this and to our sponsors, Johnson & Johnson and Bristol Myers for supporting this Grand Rounds series. What we're here to talk about today is about coronary physiology. This is something that physiology has been around for several decades, but has had pretty much a very important, I would say, revolution over the past few years that some people have called it Physiology 2.0, modern use of physiology, but there's just this whole array of tools that have become available that I would say even for the practicing interventional cardiologists has been hard to keep up with about what's happening in this field. So the purpose of today is pretty much to, again, this is something that each of these themes, I see Dr. Lutzer and I see FFRCT, each of these themes could be probably a half-day session, but the idea is to provide an overview of all these emerging technologies that have been coming out over the past several years. I do work with many of these companies in this field very closely. So why is physiology relevant? Why does it matter clinically? We're taking care of patients. Why does this matter? Well, it matters because we're trying to address the crux of the issue in two aspects. One is we're seeing patients often that have some sort of symptom that we think might be from angina. We're trying to understand, are the symptoms caused by coronary disease? And is that coronary disease because of a problem in the large pipes, in the epicardial coronary arteries? Or could the patient have potentially open or non-obstructive coronaries and have a problem in the microvasculature? So the first issue is more of a pathophysiologic and symptom issue as to how do we address whether when we see a patient in clinic or in the hospital, are those symptoms actually being caused by a coronary problem, and how do we answer that? The second one is we're trying to figure out now how to target therapies. And we're trying to understand who are patients that we may want to treat medically and who are patients that we may potentially think we want to offer coronary revascularization, let's say with stents. And we'll use things like coronary angiography and even CT, but there are tools that often many of us perceive as the gold standard, let's say like as an invasive coronary angiogram, that as you can see here below have this whole array of limitations, two-dimensional representation of a three-dimensional volume. I look at a lesion and I call it 40%, my colleague call it 60%. Calcium, we don't opacify the vessel sufficiently. Even from CT, as you show here in a straight multiplanar reconstruction on the right, is this lesion ischemic or not? There are a number of limitations from anatomy alone, and therefore that's the reason why physiology is relevant, because again, we're trying to understand how to diagnose a problem and how to better target therapies. Now think about those issues, and I think those issues are crux to any medical problem, right? We either want to make patients live better lives, improve their quality of life, if possible, try to make them live longer, or at least live longer with less adverse events, all right? Those are the goals of anything in medicine. As we get started, I think this is actually a timely publication. This just literally was published this month in Circulation. As you know, there's been this whole series of Orbita publications that have been very transformative over the past few years because they've compared to placebo. So this is the latest analysis from the Orbita 2 analysis, which again was just published January 21st in Circ, and I would invite you to look at it. But what was very elegant about this publication, again, is that now they have this ability to evaluate placebo control results with respect to symptoms and exercise time across everybody that they measured both FFR and non-hyperemic pressure ratio. And not surprising to many of those of you that have been practicing many for years, but it's something that often has been questioned, but this elegantly demonstrates, I would say in the first time in a very robust fashion compared to placebo, is that the lower the FFR, of course, the more likely that patients are going to benefit from PCI, and they're going to have a higher exercise time. This is not necessarily something surprising, but it had not been ever compared to placebo. And therefore, it really confirms that in patients that have significant ischemia, you improve symptoms and quality of life, which is what arguably we try to do in patients with a stable ischemic heart disease. The other one is, as I mentioned before, we either improve quality of life or we try to also make sure that people doing the long-term follow-up, short and long-term follow-up, they have a good quality of life and follow-up without events. So the other one is, if possible, we want to make people live longer or have fewer bad issues happen. As you can see here at the table, this is one of the probably biggest and most robust data sets on this, the FAME2 trial that compared FFR to medical therapy that showed that FFR-guided PCI was superior. As you can see from the table, it's not with respect to mortality, but there's a signal towards fewer myocardial infarctions and revascularization. So just to start in the point of the discussion with the presentation here this morning, that again, that's the whole thing. We're trying to use physiology for clinical purposes to make patients live better, and try to address their symptoms and have fewer adverse events. Now, what do the guidelines tell us? The guidelines, I won't go over this whole table because this is the summary of all the major international guidelines, ACC, AHA, and ESC. But in general, the message is highlighted in yellow and with some arrows here in green is that there's very high level of data and recommendations that one should use coronary physiology, particular FFR or non-hyperemic pressure ratios, particularly in intermediate stenosis, to try to answer the question as to whether these are patients that could potentially benefit from revascularization or are better managed conservatively. And as you can see here, FFR gets class 1 in the American guidelines for chronic coronary syndromes. They even have this new statement that you don't, to be honest, it's not as often used in prior guidelines. They call it a cost value statement of high value, that if a patient does not have a previous stress test and you use FFR, this is of tremendous value. FFRCT gets a class 2 in the latest chest pain guidelines, and in the ESC, several of these modalities get class 1. But again, this is something that is strongly recommended in our clinical practice guidelines. Before we talk about some of the modern things that I want to talk to you, I really think it's important to talk about when did this start. You know, I think a lot of us often go to the original paper from Andreas Grunzig because this is the first paper of balloon angioplasty that really started this field of interventional cardiology, not necessarily hemodynamics and catheterizations, but the world of PCI started here in 1979, published in the New England Journal of Medicine. But what we sometimes may overlook is that the guy was a pioneer. He said at the time, you had a balloon, and as you can see, the balloon had a lumen for pressure recording, and he wanted to document what was a translational pressure across that lesion. And I do want to play this video so you can see how sometimes some people are really, what they say, ahead of their time. So just bear with me for a couple minutes.
What would be an ideal catheter for coronary dilatation? You should be able to control your procedure by using one of the lumina of the dilatation catheter. So the main lumen should have the capacity, while carrying the torque-controlled guide wire, to distally inject drug, dye, and measure pressure in order to give you some response of the balloon inflation, some online change in hemodynamics after dilatation, after you deflate the balloon. And such a pressure reading is very helpful, not only in defining the success, but also, as we learn in the meantime, they are predictive to some extent of the late outcome of the procedure. So we have already some points which are ideal together. A catheter which is able to measure pressure at the end port with a steerable guide wire in place, a balloon which is almost unbreakable, and a profile as small as possible to sneak it to the most severe stenosis, even if it's calcified. So that would be the ideal catheter.
I think that's fascinating, right? I mean, I think a lot of these problems that we're talking today, and I'll be talking to over the next hour, are what he was talking in that video in 1979. The issue of understanding how to predict response and prognosis. He was talking about this in 1979. And I don't know, you've probably heard me say this at other talks, I really like this concept of adjacent possible. So and sometimes you have a great idea, but as they say, it's ahead of their time. Like you can have a great idea, but if the technology, whether that's software or hardware, it's beyond you, then it's just a great idea. So this was a great idea of what he's talking about in 1979. The equipment is not available. These are the catheters. It's a 2.8 French infusion catheter that tapers, and pretty much, in short, at the time, there's no reliable device to measure coronary pressure. The catheters are big, and the concept of hyperemia is not yet recognized. So great idea what he says in the video. Technology is not there, right? So for that reason, our field of PCI starts performing balloon angioplasty to improve symptoms, but some of this concept of being very precise about physiology were not really there yet. Now, all this changed, of course, particularly and got adopted into practice with the FFR trials. So think about that catheter that I just showed you, bulky, big. Now, in 1994, the first pressure wire commercialized was the Ratty wire that was commercialized at a large level. This is now what we recognize as the avid pressure wire, but this is where it starts. And as you can see, it's really not that long ago. This is a very still relatively early field. 1994, 1997, you have the first validation studies of Ratty, and the clinical trials just in the late 1990s. So I would say this is now what we're talking about, more modern coronary physiology, the birth of it, and this led to many of the trials that I see many of my interventional colleagues here, to the series of these FFR trials, the FIR, FAME2, which really establish the crux of the evidence that supports those guidelines that I just mentioned that were Class 1 recommendations. So these trials in general, what they say was two messages. One message is that, particularly from the FIR, is that if your result is quote-unquote negative, in this case was above 0.75, those patients have favorable outcomes, and therefore you can defer PCI. But also in the FAME trials, particularly FAME2 that I showed the 5-year outcomes at the beginning of the presentation, that if you use coronary physiology to identify patients that have ischemia, that is superior to angiography-guided PCI, and even medical therapy to reduce myocardial infarction. And this is what established the use of physiology. Now you would say this is all great, we should be using all the time, right? Because of course we want to do precision-based PCI and make sure that you are using these technologies to the best of our capacity. Now this is the latest data that I know that shows this as clearly. It would ideally be nice to have some more updated data, but this is from 2016. Despite all these trials, this tremendous work, multiple randomized control trials, the use is very modest around the globe. In the US, it's more than 10%. For the purpose of time, I've eliminated this slide, but there's an analysis from Bill Fearon across the whole VA hospitals that maybe it's in that 10-20% range with some variability across the VA hospitals. But again, great data, not adopted. So therefore, some people said, well, can we make this easier? Why are people not using this? I mean, we want to understand who are the patients that benefit or do not benefit from revascularization. Can we potentially make it easier for the cath lab? And there was some concern that hyperemia, for those of you that may not be familiar, the concept of FFR is pretty much that you're measuring a pressure proximal to the lesion and distal to the lesion, and you want to equate pressure to flow, and so you have to eliminate resistance. So people will give drugs, whether that's adenosine or papaverine, to eliminate the microvasculature response and pretty much equate flow to pressure. So that is something that's done all the time. We do it all the time, but requires a drug. The drug can sometimes create arrhythmias, bradycardia, cost, time. So what if we make it a little bit simpler and get rid of the hyperemia to make this a little bit more practical? And this led to the birth of what people call the non-hyperemic pressure ratios. There's a whole array of them, but the concept is the following. The concept is that during what they call the wave-free period in diastole, here is highlighted in this sort of like orange color, and here green, there is minimal variability. And during this wave-free period, you can get pressure differences that are able to be reliable to make decisions about whether lesions are severe or not. And the first such technology that came about was IFR, which is something that you've probably seen in your clinical practice that many of us use regularly. Following the birth of IFR as a reliable metric, a number of other technologies came about that showed that they provided similar response. All of them get under the umbrella of NHPR, non-hyperemic pressure ratios, and it's the soup of letters, IFR, DPR, DFR, RFR. They're all the same concept relatively. IFR is, of course, the one that has the large data. They have now, we transitioned from the FFR trials to now the IFR, non-inferiority trials. These trials were not trying to show superiority. They were trying to show, are we as good as FFR? So these are the IFR Sweetheart and the Fine Fleur studies. They were published both simultaneously in the New England Journal of Medicine, and pretty much these were now large trials of thousands of patients that showed that IFR-guided care was non-inferior to FFR-guided care. And this is the reason now, over 10 years or so ago, this non-hyperemic pressure ratios, specifically IFR, because there was one that was studies in these two studies, really got incorporated into clinical care. And some of the reason it's been further incorporated is because some of the argument has been said, look at trials such as IFR and IFR Sweetheart together, they have randomized way more patients than all of the FFR data. And therefore, some people have made the argument that this is therefore another reason to use more of the non-hyperemic pressure ratios, even though they were not superiority trials, they were non-inferiority trials. One quick slide on this, because I think this is where the field now is having this sort of like transition, is like, of course, where as interventional cardiologists, we want to make it something relatively easy. So this concept of doing no drug, doing a quick measurement, it's very appealing. We got it, we do a measurement, we're done. But it's increasingly now recognized, and there's now a number of publications that it's now not that simple. There is discordance between IFR and FFR. This is a type, it's between IFR and HPR and FFR in 20% of cases. And this is a study after study after study showing that there, again, the discordance between non-hyperemic pressure ratio and FFR is 20%. So therefore, how do you choose? And this is just a reason that I would say there's been this wave back of using more FFR for a number of reasons. Think about our clinical practice. In our clinical practice, Dr. Lesser will measure in the CT lab FFR CT. Then we have now angiographic FFR in the cath lab. So if you go ahead and measure at non-hyperemic pressure ratio, you're comparing apples to oranges, because we already know at the upfront there's a 20% discordance. So therefore, my editorial comment is that you have to compare apples to apples, an FFR modality to another FFR modality. And similarly, just very interesting how this publication, as I've mentioned, there's a lot of interest in this field. This was just another publication, just came out in circulation this month, showing that in a large data set of thousands of patients, that it is when there's this discordance pattern, same thing, 20% of patients, patients that have a discordance with a positive FFR do better revascularization. So just be aware of the signal that we sometimes want to make things simple. There may not necessarily be as much. And again, my interventional colleagues can maybe at the end pitch in what they do or their practice or interpretation. I will say from my side, I've been measuring now all these indices pretty regularly because of some of these issues that are being increasingly recognized. So now, I provided a background on the guidelines and the major trials. So the purpose of the grand rounds today is, can we do better? Like, we underuse the technology despite strong data, and unarguably, you would say, why are we talking about this? This should be a one slide. The trials of a stable ischemic heart disease are negative. Let's go out and have some coffee and relax. Because this is the Courage in Ischemia trial that showed that PCI are not any better than medical therapy, right? And I show this slide in several talks about PCI because I think it's important for us to be humble about what we do. And the reality is that we think about interventional community as a whole. We don't use enough radio, we don't use enough imaging, we don't use enough physiology, and therefore I remember training with Nick here, and he would say, put the big stent as much as you can, get an IBUS and put a big juicy stent. We don't use imaging enough, so we put small tiny stents. So all these issues add up and lead to this epidemic of ISR and repeat revascularization and poor outcomes. But talking specifically about physiology, we don't use physiology enough. So I want to invite you to a concept. These trials, such as scourge and ischemia, they treat coronary disease as if it were the same disease. You have a binary disease, you have coronary disease that it's ischemic, and therefore we are going to treat you the same way. Randomize you to revascularization or medical therapy. It assumes we all have the same disease. But is that so? So maybe I'm going to pick on one of you for the sake of discussion. So Yvonne, maybe I'll bug you here, Yvonne. So here you see the distal FFRCT is 0.63. Let's forget about the technology. This is just an illustration of the disease. This patient has an LED lesion with a distal value in the 0.6 range. Agree this is a tight lesion, right?
Yes.
This patient also has numbers distal in the same values. Dr. Lesser will correct us that there's some pressure loss distal, small vessel, but technically speaking, both have the same FFR distally.
Approximately.
This is a problem of what I'm trying to address of phenotypes of coronary disease. These two patients, in many of the trials and studies that have been done in the field, get called coronary disease with an abnormal FFR in the similar range. To all of us looking at the slide, these are clearly two completely different diseases. The disease on the left, it's a PCI with a stent from here to here that gives you a great result as an operator, to the patient, symptoms, quality of life. These patients require a little bit of a beta blocker in nitrates and aspirin and prevention. But they all get treated the same. This appears obvious, but we haven't been doing this in our trials. We haven't been doing this often even in clinical practice. So again, this is a concept that is increasingly being recognized. Now, graphically talking about this is how to better phenotype coronary disease. Here's a patient that has a proximal coronary artery disease lesion, significant pressure drop with an FFRCT of 0.70. This is the patient that you can gain a significant improvement in flow and fractional flow reserve and can go to 0.95 with one shorter stent and provide a lot of satisfaction to everybody, particularly the patient, because the patient will feel better and achieve all the goals that we already mentioned. Now, the other example is what I just said. Patients with diffuse coronary disease, they have the same FFR result, but the pressure drop is gradual. You will end up putting long stents, and your FFR result will be suboptimal. These are patients that I'm not saying that they don't necessarily need PCI. You will improve the FFR, but it will not be to the same degree that focal coronary artery disease. But in the trials, this such distinction never occurred. So in patient trials like ischemia, courage, they're all treated the same way. So this is a concept that I think is being increasingly recognized. And now we have, as I'll talk in the next slide, we have this number of technologies that are able to better measure this, such as like this one that I showed at the beginning, such as just non-invasively from a CT, provide that phenotype of coronary artery disease and answer that question at the upfront. So this brings me to bringing CT to the cath lab. This is, of course, something that you've already heard from us over the past years. So Dr. Lesser, Manos, many of you here have been closely involved in this field. This is something that has changed. A pioneer like Dr. Lesser has been doing this since, 2012, John, or? 15, yep. So a diagnostic tool that we, you measure, put your marker. The recommendations would be 1 or 2 centimeters distal to the lesion. Is it abnormal or not? But we've learned, particularly now, I would say, us in the cath lab, not our colleagues, the readers that look at this all the time, but we've learned how we can incorporate this now to literally address what we're talking about just a few slides ago. How to, particularly on the right, how to address the phenotype of coronary artery disease by doing virtual pressure pullbacks to understand whether the lesion is diffuse or focal. So this is now Physiology 2.0, in which you incorporate non-invasive tools into the cath lab to also have discussions with your patients about the expectations of what you might or might not achieve with your procedure. And critically, now Physiology, again, Physiology 2.0, we've transformed a diagnostic tool to a therapeutic tool, in which you, for those of you that have been involved in some of our virtual PCI, CT-guided PCI work, now you can incorporate this physiology work now to do predictions of what is the FFR in the absence of the lesions. And as you can see, for example, you can use these estimations to understand if you put a stent from here to the middle AD to the proximal LAD, how your FFR value may go from 0.68 to 0.80, which is better, but it also illustrates the fact of what we just discussed, that there's probably some diffuse disease, and therefore your FFR value, despite 38 millimeters of stents, it's not 0.9. This is an important evolution in coronary physiology that probably we appreciate how important that is for discussions with the patients about expectations and us and operators as to what can be or not achieved in the cath lab and what are our results despite sometimes great cosmetic big stents in some areas. This technology has been validated in the P3 study, very elegant study. For those of you that are not familiar, all these virtual PCI modelings were measured against high peremic pressure wire pullbacks and shown to have great accuracy, and therefore we do this, have been doing this actually in our practice now for a couple of years. There's now even ways, there's been this whole series of AI talks that you hear from AI Echo, AI ECG, all these things that have been a number of grand rounds. Not to your surprise, there's now efforts and now a product that also predicts AI, the FFR from the CT data. Dr. Cheng is very involved in this, and I know he's given some grand rounds on this before, but again, another issue of how AI and all these things are a very important topic. So we talked about CT before you entered the cath lab. Now we've entered the cath lab. What's new in the cath lab? This is not necessarily new, but I would say it's underutilized tremendously. So we talked about IFR and how the IFR trials came with the Fine Flare and Sweetheart. They were non-inferior, but there are technologies also to better improve the understanding of where the lesions are angiographically and where pretty much to treat. This is the same IFR that we are all familiar with, but pretty much there's nothing special to do about this. This is pretty much you do your IFR, you stay on the fluoro, you pull the wire as you remain on fluoro, then you stop, you take a picture, and it's going to co-register the IFR with the angiogram, and it's going to put one circle across the vessel that each circle represents 0.01. Of course, it's clear in the angiogram that there's a tight lesion here, so this is an obvious example. But in examples of serial disease, tandem lesions, it sometimes becomes very important to understand how long should I stent. And here you can actually interact with the software, and you can place virtual technically, let's say, do virtual stenting and cover lesions to understand what would be the IFR predicted in the absence of such lesion. This is a technology that's out there. It's called angiographic co-registration with a sync vision system. We actually have it in all of our cath labs, and it's something that can be used to complement what it would be, I would say, Physiology 1.0 of IFR to now using Physiology to guide therapy. Because similar to the concept of what we were just talking about CT, you could see an abnormal IFR, and you could, with this tool, also understand whether you would improve the IFR or not. So again, an important technology. Something important, this is not new at all, but I do want to highlight, and that's the reason I added this slide here, is that an important issue in coronary physiology, I would say it's education. As I've mentioned before, there was this whole, at least from my perspective, and I feel I've lived through some of these things, at least early in my training, we're still using a lot of FFR, then everybody changed to IFR, because again, it made sort of sense, simpler, easier to do. And there was the idea that doing all these measurements took too much time. Before we talk about the measurements, I want to tell you that this is a comprehensive coronary physiology assessment of non-hyperemic pressure ratio, such as like IFR. This one is called IFR, a resting PDPA, FFR, and even a pullback. What I want to highlight you is the time. 1619, 1619, 1621, 1621. It takes like less than 5 minutes to do a comprehensive physiologic assessment in the cath lab. And this provides all the information you need. You get the initial non-hyperemic pressure ratios we discussed about. You can do PDPA because that's just pretty much pressure difference without hyperemia. You can give hyperemia because you have it ready, and there's a number of ways to do that, IV adenosine, IC adenosine, or papaverine, and you see that there's an abnormal FFR, and then you just push your wire, pull your wire, and you see that there's a very focal lesion and pressure gradient. This is something that maybe we have not done enough because maybe the wires previously have been not good enough, perceptions of time, of whatnot, but I can tell you that we've been working very hard with our techs and our teams, and this can be done now in less than 5 minutes, and you get a lot of information. Why is this important? This is important because this is an important innovation in coronary physiology as we move forward. I'm not sure how many of you have heard of this concept of PPG, but it's something that you will likely hear more and more. This is the pullback pressure gradient, not yet clinically available, but being studied in trials. Our colleagues and good friends Bernard De Bruyne and Carlos Collet actually have been doing a lot of this work. But where this is changing is that, again, we're trying to move towards phenotyping coronary artery disease. And again, now this software is what they're doing. Right now, this is still investigational, but the expectation that, this will probably, hopefully be clinical at some point, is that similar to what we do with CT, that you can understand the phenotype of coronary artery disease, now you can pull back the wire. And again, this has always been appreciated, somebody would say, by pulling the wire and glancing at the waveform, but this is sometimes a subjective assessment. Now, as you pull back the waveform, there's objective quantification of the pressure loss as you pull as you pull back your wire through the vessel, and you get, as pointed by the arrow, an actual number of the gradient of what's called the PPG, the pullback pressure gradients that takes into account the pressure, the change across the vessel, and the length of disease. And this allows you now, in an objective fashion, as shown on the left and the right, to now address this issue of coronary artery disease phenotypes. Whether, as shown on the left, it's a focal lesion with lipid-rich plaque burden, thin cap fibroatheromas, more vulnerable plaques that benefit from PCI because they have a high translational gradient, or whether it's a lesion that has a similar abnormal FFR, but it's more from diffuse disease, which what people would refer to a low PPG. This is the one that you may want to treat potentially medically or think about alternative options. This is the future of coronary disease, to improve phenotyping, whether that's with a number of tools. We talked about CT. Now this is how this is trying to be addressed in the cath lab with wires. And these two slides that I had, this one of angiographic co-registration and this one from PPG, they're trying to get at the same concept. How do we better understand not just a distal number as if it were a pregnancy test of abnormal, but what type of coronary disease it is. Why is this important? This is a PPG Global Registry published in Circulation last year. And the reason this distinction is incredibly important is because, as you can see here in red, you have diffuse coronary disease. When you have diffuse coronary disease, not to your surprise, but elegantly demonstrated here, you have more target vessel failure, but importantly, you have more myocardial infarction, largely driven by peri-procedural myocardial infarction. So again, not surprising, you have diffuse disease, you're putting lung stents, you have more adverse events. So phenotyping coronary disease allows you to better understand not only how to treat your patients, but also gives you a sense of the risk of the procedure. Now, with pressure wires as well, this particular one, I wouldn't say it's necessarily an innovation, but it's also the same concept. So we've talked here how you, in less than 5 minutes, can get a comprehensive physiologic epicardial assessment. Let's pretend everything is totally normal. These wires, the one that I'm showing right now is the one from Abbott. This is the Abbott Pressure Wire X. With Doppler, you can do this, but the Doppler wire has not been available now for a couple of years for separate reasons that we can discuss offline. But right now in clinical practice, what's used right now is thermodilution. So with the same wire, if you wanted to, again, this takes you technically just less than 5 minutes more, you can just do saline injections 6 times, 3 before, 3 after. You see the 3 boxes here. And just by doing 3 saline injections without hyperemia and 3 saline injections with hyperemia with a medallion 3cc syringe, you can add to everything that we just talked about CFR and IMR and tell whether the patient has microvascular disease or not. These are things that are sometimes perceived to be academic or complex. This literally takes less than 10 minutes. And this is a saline injection with a 3cc medallion and gives you now, you can see in probably, I'm going to just estimate, less than 10 minutes, a comprehensive assessment of everything. What is the innovation in microvascular assessment and thermodilution? One is that while this is a very practical assessment, and Dr. Sharkey and all his work that he's done with thermodilution and Swan-Gansen, Well, this is variable. And you can even see this here in the waveforms. You can see how the waveforms are variable, similar to what happens with the Swan GANs. So therefore, the innovation has been, and we've actually, I want to say that we probably are the center that has done the most cases in the United States. The innovation is that rather than doing manual injections of saline, now pretty much we connect a microcatheter to the injector, and by connecting the microcatheter to the injector, we set a rate of saline, and therefore there's no variability in the waveforms as we measure thermodilution. This is no longer bolus thermodilution. This is now continuous thermodilution. And the beauty of this is, as you can see here, is that now for the vessel that's being interrogated, you get vessel-specific flow and resistance. This is very unique for pathophysiologic, phenotyping, microvascular disease, that you can go to an individual person that has some symptoms and get actual numbers of here. Like in this patient that I did a few weeks ago, that the flow in the LAD, it's here, it is 202 milliliters. It's like, this is the precision of what you can do with continuous thermodilution, and this is a totally separate talk for maybe a future grand rounds on 2.0 microvascular disease assessment. But now when I report these cases, you can say this is the FFR, this is the CFR, but now you can report things like hyperemic resistance and the microvascular resistance reserve. So you can report very comprehensive assessments of flow and resistance in the vessel, which many people would say this is at present the gold standard of the most precise way to measure coronary microvascular dysfunction in the cardiac catheterization laboratory. So why do we have to do this grand rounds, and why there's a need for education? I mean, I'm sure we could ask some people in the room here, and even for myself for several years, this is a journey of learning, of I think about Manos, never-ending learning, a continuous learner. This is a soup of letters. So how in a field that we're expected to do structural interventions, peripheral interventions, interventional cardiology, clinical care, a number of things, how do you keep up with this? This slide shows all the stuff that's happening. There's FFRCT, there's AI ischemia, there's a number of angiographic derived indices, there's epicardial indices, there's FFR, there's NHPR, microvascular, there's even intravascular imaging that derives that I don't have the slide, but there's this concept of VFR, which is an FFR derived from OCT pullbacks. This is all happening. With a yellow box are the ones that we have in our hospital right now. All the ones with a yellow mark, we have them. It's very hard to keep up with this. But just be aware that all these technologies have, as any technology, have particular advantages and disadvantages. And this is where there are some people that I know would even refer to them as interventional physiologists because of the complexity in this field that with all these technologies that are coming up. So we've talked about CT, we've talked about wires. Now what is coronary angiography 2.0? As we talked about technologies, and here I'm highlighting it here, that's something that we have. We do have angiographic FFR. We've had it now for over a year. We're actually, I would say, I think we're the highest place in the state that has done the most angiographic FFR. And pretty much this is now 3D reconstructions of the coronary tree from the angiogram, 3 pictures, and these 3 pictures will pretty much create this model similar to like what you say, let's do with FFRCT, and from the angiogram, by taking 3 pictures with no panning, they're able to compute the FFR, taking into account how this comes from the DICOM, no panning, good quality pacification, TIMI3 flow, TIMI flow, and they're able to compute FFR. These are all the technologies that are either available, research, or in the pipeline. Again, I'm showing you one that we have clinically available. There are all these technologies out there around the globe of how to estimate angiographic FFR using all this novel computational that integrates some degree of AI and flow measurements. Again, the one that we use clinically in our hospital, and this was because it's FDA cleared, because it was shown to be accurate enough, it's FFR angio. So FFR angio was evaluated by Bill Fearon and Bernard De Bruyne in the FAST study. They measured this against FFR, shown to have an AUC of 0.95, and showed to have very good sensitivity, specificity, and diagnostic accuracy. Some of these numbers have been questioned with some of the other technologies, but because of data like this was FDA cleared, and therefore it's clinically available, and we have it. We were actually part of the trial. I don't see John Rickard here, but John Rickard and the research team here enrolled a number of patients, and I see many of you that enrolled a lot of patients in this trial here at Abbott, and we were part of the All-Right study, just completed enrollment last month. This is a pivotal trial randomizing FFR angio against pressure wire guided treatment. Again, this is a clinically available technology because it's considered to have a good diagnostic performance. Actually, I see JJ, I think, was the highest enroller on our site. But the question, of course, is this as good as the standard of care of FFR? So people will be very eager, I guess, 12 months from now to understand whether this is a non-inferior as compared to FFR. This is how we do it. This is one of my cases. I had a middle AD lesion. From the angiogram, you take 3 pictures, and from taking those 3 pictures, you can create these 3D reconstructions that take into account flow, vessel contour, and are able to estimate FFR from the angiogram. As mentioned already, this has been validated to be accurate. You can see that the FFR is 0.76. You can even do a lesion impact and predictions of what happens to the FFR if you implant the stent, and pretty much this makes it no excuse to do physiology in the lab. You don't need a wire, you don't need a drug, you just need to take good coronary angiography. All these technologies are being evaluated in a number of trials. I think over the next 2 to 3 years, we'll see a multitude of trials coming out. I won't go over all the slide, but as you can see, all these various technologies are being evaluated in various randomized trials, often of pretty good sample size, and this will be incredibly important to understand whether this technology takes it to the next level or not. A recent trial that raised actually some questions about this. It's one with QFR, just published at TCT. This is one of the earlier technologies that came out. This is with 2 pictures, not 3 pictures, as FFR angio, but this technology actually showed that the rate of adverse events was higher compared to FFR, which has created some degree of pause in the excitement for the technology, and therefore this trial that we were just part of, the All-Rise, has taken incredibly more importance as to understand what happens with this novel angiographic indices. Now, as we wrap up here over the next minutes, we've talked about the journey, and that was the intention, almost like in a patient journey perspective. We've talked about CT, we've talked about wires, we've talked about angiograms. Now, how about post-PCI physiology? This is, again, something that maybe historically hasn't been as an exciting concept because it took time or the wires were not good enough. But now, following what I just mentioned, we can just take a couple of pictures and compute FFR angio and say, did I achieve a good result? Is this important? Well, I would like to think that 100% of my PCIs are highly successful. But when you look at all PCIs that are considered successful, and Manos, I think, was the site PI for Define, 25% of PCIs performed have a suboptimal physiology. I think this is another of those topics that is like, we need to take a step back and be humble about our field. These are stenting procedures that were considered to be good, but when physiology is measured, only 76% of them had an adequate physiology at the end of the procedure. Because of these reasons and the fact that the results are suboptimal, but associated, as mentioned here, with adverse events, there's now also a lot of interest in post-PCI physiology. There's now the Define GPS study, which integrates what I mentioned before of using IFR and co-registration, but here, as pointed in this yellow box, seeing whether the IFR target of 0.95 is achieved or not following PCI. So this is being tested in several trials. Define GPS with IFR is one example. This is another example of how these technologies are being incorporated into clinical care. We have this in our cath lab. I would say we need to potentially use it more to understand the opportunities or not with this, But this technology is available in clinical practice right now in our labs. And as you can see, you can do the FFR angio that we just did, that the lesion is abnormal. But the latest software shown here is that therefore you can do estimations of what if that, similar to FFRCT and virtual PCI, what if that lesion was not there? If that lesion was not there, or which is hypothetically saying if you treated it and put a stent, if you treat those two lesions, your FFR would go to 0.94. Using these estimations give you, as mentioned here, here's this tool on the right, understanding of stent length, and also understanding of expectations. So this is increasingly being incorporated into different softwares. I can already think of 3 at the top of my head right now. And of course, it begs the question, what are we trying to target? I don't know that we know with certainty what the target is. This is one secondary analysis for DK crush that suggests that maybe we want to target at least an FFR of at least 0.88. Again, some people would say 0.9. Some people would say it's hard to specify by vessel because there's variability, but this is something of great interest. Why is it important? One, because as I've mentioned, suboptimal FFR is associated with adverse outcomes, but also because there's interventional data that if you measure it, there are actions that can be taken. So if you measure it, and to me the best example is with virtual PCI. If you use something like FFRCT virtual PCI and the target FFR was 0.88 and you measured it and you achieve a 0.81, that tells you I'm missing something. And this study elegantly showed this, not with CT, but the same concept, that if you measured it, you identify opportunities for post-dilation, additional stenting, geographic miss, or you need to image more. So if you measure after the procedure, you understand that there's opportunities to do better. Now, my final point here to wrap it up is what are the future directions and opportunities. One that I do think was important to include here is that now there's a lot of interest in trying to, we often think about physiology and anatomy in sort of like in different bins, but increasingly there's a lot of opportunities to try to merge these fields. This is something about how can we use physiology now to identify these high-risk lesions of vulnerable plaque, which integrates some of the concepts that I've mentioned before of PPG and FFR. And again, when you look at this and look at what I'm going to tell you and look at the picture, it will be like, aha, this is not surprising, but it had not been demonstrated before. So the lower the FFR value and the more focal the disease, so the higher the PPG. These are studies that have done physiology in a comprehensive, systematic fashion with an imaging modality like CT and OCT. These are the patients that have vulnerable plaque, which highlights further the concept. These are the patients that are probably more likely to benefit from our interventions that we can offer in the cardiac catheterization laboratory, because these are the high-risk patients with focal lesions and very low FFR values. The reason I'm saying that is because it goes the same way the other way around. If there's a patient that has a mild FFR reduction with a low PPG diffuse disease, that is not the patient that is going to benefit the most. As I've gone through this talk for the last 40 minutes or so, I think it clearly highlights that I think there's also a modern coronary specialist, because I think this is going a little bit right now beyond sometimes even the control of what we can do. Right now, when the field started, and I show when the field started, 1979 with Andreas Grunzig for PCI, and then the first trials in 1990s. Right now, when somebody goes to fellowship and does a 1 or 2 year fellowships, you get exposed to this, peripheral structure, coronary, congenital, heart failure. But if I just put coronary and think about everything that there's coronary, this is a lifetime and it's hard to even keep up with. You have to think about treatment of the patient with angina, acute coronary syndromes, coronary syndromes. I would say CT is part of that curriculum now, intravascular imaging. And it has all these concepts, but the modern coronary interventionalists, we cannot be just stent implanters. We need to move towards understanding physiology, the phenotype of coronary disease, better understand how this is epicardial or microvascular disease. And I would submit that as we move forward, we really need to make an effort of this, because this was just not incorporated previously because the technology was not there. Now the technology is there in any way, shape, or form you want it. When you ask trainees, are you good with physiology? Siad Ali and his group, they did this nice survey. They asked fellows, are you good? Do you feel at the end of your fellowship you're pretty good? 95% of them, I'm amazing, I'm just so good. Then they asked them specific questions to query them about whether they actually knew what they were saying. Only 50% of them actually met competency to say that they were normal. So this highlights that there's a lot of opportunities. It's even worse for imaging. As you can see, IVA is 82 and goes to 15%. So teaching these things takes a while. For that reason, in partnership with the foundation and others, we're very excited, and this will be further promoted soon. We're doing a physiology course in June 5th and 6th here at the hospital grounds with my good colleague Manos, who I see in the back, and many of you here. And we will be doing 2 days, not just 1 hour, 2 days of talking about physiology with live cases, epicardial disease, coronary microvascular dysfunction, because the idea is that we want people to get comfortable in this to hopefully improve patient care. So my final comments is that this is it. These are all the tools that we have available now. We can go from CT to pressure wire to angio and even intravascular imaging to address these various points of epicardial microvascular mix. And it has shifted from being a pure diagnostic tool to these 3 pillars, to a pillar of using physiology to understand the indication for PCI, to understand the phenotype of coronary artery disease, but therefore to incorporate this to do precision PCI, and whether that's with virtual PCI, IFR pullbacks, co-registration, all the examples that I've mentioned, to ultimately understand whether you got a good result, check whether your result was good, and understand what opportunities there are. So with that, I'll wrap it up. Thank you so much. Any questions? I'll take. Nice.
So Yader gave phenomenal work on summarizing essentially the whole history of PCI in less than an hour. But one question many people may have is about the microvascular, because that's something relatively new and many people don't know. So give me some practical advice to people if they want to have a patient, normal coronaries, but they still think it's angina and they're concerned for microvascular disease. What are the options? Who should they refer to? I know that you, Jay, do all this work. And what are the treatment options for this patient?
Yeah, I purposely didn't put as much microvascular since Joao and I, within I think last year or so, we did a grand rounds on this. But even since our last grand rounds, I think there's been some innovation that I incorporated in these slides. I would say several things. One is, again, the fields have shifted from saying you have no epicardial disease and then this is all in your mind. This is, you have no epicardial disease and you have good symptoms. We have methods to evaluate for this. We're very privileged here, I would say, at Minneapolis Heart. Joao can measure, and John with PET and MRI, they can measure myocardial blood flow. So to me, it's not about a right or wrong. You have to do shared decision making, talk to your patient. There are some patients that are like, hey, I'll start with a non-invasive task and measure myocardial blood flow, whether that's PET or MRI, that's totally fine. But I sometimes see some patients that they've had 6, 7 tests, persistent symptoms despite medical therapy. They're like, I need to know. I need to know whether I have the condition, yes or no, A. And B, also they're like, I don't know whether I want to take this 3 anti-anginals empirically because I so-called have suspected. So in those patients, I think it's very reasonable to refer them for approaching the cath lab. Those patients, again, we can do CFR and IMR on the go, to be honest. But in patients that are dedicated consultation, I think it's better to schedule them in the lab in an elective fashion, hold their calcium channel blockers and nitrates for 24 to 48 hours. And what we are doing in most of these cases nowadays, it's now what I showed, continuous thermodilution, because it's way more precise. We still do everything. We do literally everything that I showed in the slide. We go from RFR to FFR to PDPA to bolus, and we wrap it up with continuous thermodilution, and then we do spasm provocation. So my advice would say that, yes, those patients are out there. There are many patients with angina with non-obstructive coronary disease, and we're very privileged to have a number of technologies out there to evaluate these patients, whether that's with non-invasive imaging or with invasive imaging. The risk for this procedure is similar to PCI, less than 1%. And again, we have a number of technologies in the cath lab to do that. I would say there's also an opportunity, again, I think there's some of the fancier, a little bit, doing continuous thermodilution is a little bit more sophisticated, but I do think doing, that's the reason, doing bolus thermodilution with saline injections, it's something that arguably should be, a lot of people can do. There's nothing too sophisticated about that. Sure.
Yader, fantastic. Thank you for doing this sort of thing. I'm interested in the discrepancy, the 20% discrepancy between IFR and FFR. And do you know, is that in the range of 0.75 to 0.8 for the FFR relative to IFR? And how does that relate to myocardial dysfunction as far as the kind of patients who are submitted for both? If you had myocardial dysfunction or microvascular dysfunction, you may not get an FFR, you may get a higher IFR.
Yeah, this is I can say that this is a very intensely debated topics because not to your surprise, you will, as in many other technologies, you'll find that there's like two schools of thoughts and, everybody has like their sword fighting against which camp they're defending. But I will say that no matter what camp you're in, it is, here I was gonna add a third citation, but there is paper after paper after paper that shows that this is about the 20% discordance. It's just there. The reason I went back to the slide is because from a mechanistic perspective, where it appears that the non-hyperemic pressure ratios are sometimes unable to detect the problem and is those lesions that are focal. So here, as you can see here, this is FFR positive, IFR negative in focal disease. It is thought that there's not sufficient of that friction generated in very, very focal lesions that the raster ratio is unable to detect. And as shown here on the right here, you can see here that this is focal coronary artery disease is probably the subtype to be concerned about. So practically speaking, my suggestion would be if you send somebody to the cath lab and you saw in the basic angiogram of the CT a focal tight lesion, the patient had good symptoms. So they had a focal tight lesion, just doing a non-hyperemic pressure ratio and saying that's normal and walking away, it's probably a caveat. It's probably a caveat. This is the most common example where IFR could be, where the discordance occurs. Focal disease because it doesn't generate enough friction. There's to answer the other part of your question, there are some people that have some, I didn't show it here, they have done fancy studies where they've done IFR and FFR, and they've measured also CFR. And they suggest that some of these issues can also be influenced by flow, but it creates this whole eternal discussion because the people that have this discordance, the IFR, the FFR positive, IFR negative, look more like people that have non-obstructive coronary disease with normal coronary flow reserve. So it gets very tricky for me, and I've looked at this actually for years because for some reason I've been measuring these two things for a while, and I increasingly do it more because I see this and we struggle with it. It's a struggle when you measure them both. I will say that increasingly this issue of focal disease to me practically is the message. I don't have it here, but I literally the other day I encountered a great example. Patient referred to the cath lab because an abnormal CT, focal lesion, markedly abnormal FFR CT, and non-hyperemic pressure ratio total was negative. So this issue of friction of focal disease would be my messages on this aspect. I don't know if that answers your question, but this is, I would say this is the clinical messaging from my view. Go ahead, Denise.
Thank you very much, Dr. Sandoval. This is an elegant talk. So my question is, what if we have multiple tandem focal lesions? So it's the non-hyperemic, we know FFR can decrease the, the sensitivity can be decreased, but I don't know, what if we have it and we have
No, tandem disease, I would say, from my view, tandem disease, if it's real tandem disease, now we have a number of ways to get at it. The most elegant and modern approach to do is going to be FFRCT and virtual PCI. The beauty of it is that if you have 3 lesions, let's say, or a couple of lesions, and you don't know which one to treat, and you don't want to guess, you just drop a virtual stent and see what correcting which pressure loss will provide the best translational result. So to be honest, that's the most elegant way to do it. But if you don't have that and you have to do that in the cath lab, this is the reason the co-registration. It's a great tool because in diffuse disease, you're going to see multiple of those yellow columns. And therefore, you can understand whether you have to put long stents or tendon stems, or whether maybe the tendon lesion that you thought was important was not relevant. This is the reason we probably need to do more co-registration. And the other one is this one that I talked about, doing pressure pullbacks to understand whether the diffuse disease has some high translational gradients that benefit from PCI, or whether it's just diffuse disease that you just want to treat medically. So I would say we actually have a lot of now emerging technologies to answer that. But it's a great question. Yeah.
Yader, phenomenal talk, and thank you for educating us. in a practical term, when you see a patient back in clinic that has been stented elsewhere, the two things that comes to mind is that, how is the stent doing, but also did I cover the enough lesion? Where is this microvascular disease? Practically, where do you start? Of course, you might want to start obviously with medical therapy, but once it is refractory, where should we start thinking, and when do you take this patient to the cath lab?
You say the symptomatic patient post-PCI.
Post-PCI.
Yeah, the symptomatic patient post-PCI. I mean, I would say that if they have, class 3, 4, Canadian class course, if they have real angina symptoms post-PCI, I'm gonna go with maybe they need to come back to the cath lab and then understand what's happening. If the symptoms are more like those, like quote unquote atypical, you're not really certain, I'm gonna defer to you guys and your great non-invasive technologies. Again, I still order, as much as I like CT, I will say that I order a lot of PET. And I do feel that myocardial blood flow, PET for ischemia, but also getting the vessel-specific myocardial blood flow, I find that very helpful. So I don't know that there's a right answer to that. To me, it depends on the clinical context, the magnitude of the symptoms. And to be honest, also reviewing the old angiogram, I think, there's separate from this but related, is that, we're also learning how long should our stents be. And something, I'm sure here may have different perspectives. Some people are more like a short stent just to the right lesion, but if you look with OCT, IVUS, or CT, the disease is long with maybe vulnerable plaque on both sides and maybe should have been covered, and maybe that's the cause of the symptoms. This highlights the issue of the opportunity of measuring the physiology after the end of the procedure. Because when you're seeing the patient in clinic, it is helpful to say, hey, this was a good result. The post-PCI physiology was X. Problem is that, understand that, sometimes we don't want to know when after our great work and 2 hours in the cath lab, however far west, 0.82. But yes.
Is there any use for myocardial mass assessment per vessel except for side branch assessment in the cath lab?
This is something that has has been of great interest to us. With Manos, he can speak to it since we're doing. We've had a lot of interest in this lately. For the purpose of like this talk physiology alone, I would say not to this, but for the purpose of PCI, I think there's a number of elements of myocardial mass that are important. One is, as you mentioned, the side branch, but not just. To me, it's protecting the side branch, but also if you lose it. If you lose it, you understand the risk of periprocedural myocardial injury and infarction. It does become relevant because if, let's say myocardial mass was incorporated into routine clinical care, and you had a side branch that had a 1 or 2% versus 10%, you would have different, it would have different connotations as to where you observe the patients, whether they need an overnight stay, what they need, or maybe you want to rescue more proactively, and also even potentially whether how you stage these procedures. Let's say you have multivessel disease. You may say, I want to treat the one that has the most mass first, maybe the other one later. So all these things I think we're sort of learning.
I was thinking about in answer to Joel's question. Okay. So if you had a side branch that had a lot of myocardial mass, maybe would there be some threshold for symptoms?
Oh yeah.
In thinking about the post-procedure.
Yeah. I think that would change my procedure.
But even if you didn't, because you didn't know it,
right?
Now
because if
seeing you.
Yeah, if you have, I think the biggest mistake I make is you underestimate what the diagonal mass.
Right.
And then I would change my strategy, the stenting strategy up front. I wouldn't need a CT ahead of time. I mean, I think we should be doing more CT, to be honest.
You had a question in the back?
Yeah. So with all this information we're getting, and I'm thinking what we do with surgery, because I know sometimes you just suggest cavities as a possibility, but we should be a little more than that. Just suggest you should target this specific vessels. And I know sometimes the reports suggest it, but with all this information, we should be able to get much more results from surgery, and afterwards we should do much more follow-up too. We just follow clinically most of our coronary bypass patients.
Yeah, I mean, I think this is a topic clearly in flux, but to your point, and again, I'm not saying that this is the standard of care class 1 recommendation, but to your point, in many of these patients that have sometimes multivessel coronary artery disease, that I'm like, oh, they need to go to bypass. You have two tight lesions, but often you might be, I'm on the fence about this moderate lesion and the other one. Now we have this technology. I've been relatively, I don't want to say liberal, but I've been, proactive about saying, I'm just going to do a 3-vessel angiographic FFR for your bypass question. So I'm like, we've measured physiology in the 3 vessels. I want to send them to bypass. They have documented, and this is the FFR in each vessel. Takes less than 10 minutes, non-invasive. I sit on the back, we run it, compute it, and I don't know whether those cases you have seen them, but I do send to patients to the surgery that I report the 3-vessel FFR angio non-invasively to provide more information specifically for that. Because there's information now that, this is I think where this is going, the information is relatively now very easy to obtain. Previously, people didn't want to get 2 guides at 40 minutes and wire a bunch of stuff and cause problems. But yes, there's a lot of data, whether that's from CT or angiographic FFR, that I think will increasingly make this informative for the surgeons to understand where to
But I
go.
don't think we have graft patency data on that, do we?
No.
Because that would be my concern.
It is too
because
early,
You
too
can get
early.
a 40% FFR positive, and we've seen these go in a lima as a tretic, and what do you do with that? You just did a sternotomy for no
No, you're
reason.
right. I think there's something that, it will be a
I think
Great
that's
area-
the-
great area to
The point
study.
is the important question.
well, thank you guys. Thank you so much. Thank you.